Welcome everybody to this collaborative webinar. My name's Dr Ben Sinclair. I represent Dr Finlay's private practice, and I'm here with my colleague Professor Andrew Shaw from Attomarker. Just to give you a bit of a heads up about what we're going to do today, we are so excited. We've got over 200 registrants from around the world, and we are hoping to talk about long COVID, testing and treatments that are available, and discuss the Attomarker test in detail and look at some cases. We're going to have some questions and answers, and we'd love to hear from you if you've got any queries about what we're talking about during the webinar. Now, we've got some polls, and we'd love to know, first of all, as people join, Steve, if you could bring up a poll about who you are, why are you joining this webinar? Are you a patient with long COVID? Are you a carer? Are you advocating for people who suffer from chronic fatigue and long COVID? Maybe you're a clinician or a researcher, perhaps a scientist, or are you someone else who's interested in this subject? We'd love to know, and we're getting an overwhelming response here of patients initially, so quite a strong number of people signing up as patients, so it's great to have you with us. We're really hoping that we'll be able to give you some more insight into the condition of post-COVID syndrome. I'll just wait for that to fill out, because we've still got a few more people joining and a few more people clicking the buttons. So it looks like we're getting an overwhelming majority of patients, a few clinicians, one scientist, good to have you with us, and some others. To introduce us more broadly, my name is Dr Ben Sinclair. I'm a doctor with a special interest in long COVID and chronic fatigue, and I'm joined by my colleague, Professor Andrew Shaw of Exeter University, who runs the Attomarker project. We are going to be looking at long COVID today and trying to find out and tease out some cases and how Attomarker test might help you to understand what treatment options you've got available. I think we've pretty much done that poll. So we've got 85% of people participated. So overwhelming majority are patients today. So 85% of respondents are patients. 8% are carers. It's a really important role as a carer. So welcome to you carers out there. You'll probably be wanting more information about what you can do to help your loved ones. We've got some clinicians, 2%, 2% are scientists, and the other. I'm not sure what the other is, but anyway, it's good to have you with us. So thanks for responding to that. So today is going to be recorded, and we will put that up on our YouTube channel for Dr. Finlay's private practice after we've finished the webinar. We'd really welcome questions. So on the right-hand side of your panel, have a look at the question box there. Please fill in questions as we go. We've got the team behind us, so Ellie and Steve are going to be helping us field questions, and we'd love to hear your thoughts and questions as we go along. The background to this case of post-COVID syndrome or long COVID, it is a huge problem. 400 million people or more in the world are suffering from long COVID right now. In the UK alone, the Office of National Statistics estimates that there's over 2 million people and adults suffering from long COVID, and over 100,000 children. So this is a huge problem, both for the UK and around the world. Now, my background to this is I had long COVID back in 2021, and I had an interest in chronic fatigue. And so I really wanted to try and find out more about how to get better. I was fortunate enough to find some ways to get better myself, and started one of the first UK online long COVID clinics back in July 2021. Now, since then, we've treated over 1,000 patients, and some of those more recently have had the Attomarker test, because we were trying to find out how to solve this problem, how to help people with this really debilitating condition. Long COVID, most of your patients, so you'll know, is severely life-limiting. I was bedbound for a number of months, and a lot of us have had huge impact in our lives. So it's difficult as a carer to look after someone. It's difficult as a doctor to treat people with long COVID, and it's very hard as a patient to live with. So here we are to try and discuss this and try and move that forward. The background to this really is that it's a very difficult and new diagnosis, long COVID. And more recently, we talk about post-COVID syndrome, which is everything that happens after someone has an acute COVID infection. It's a very complex presentation, and some people are much more severely affected than others. Now, what we're trying to do as doctors and clinicians is to understand why some people are more severely affected and find treatments for those people who don't recover through just natural means. And so on my journey through this myself personally and with my patients, I was looking for answers. I was looking for tests, and really a bit like a dog with a bone, I would not stop until we got answers and treatments that are going to work. I was introduced to Professor Andrew Shaw of Exeter University because we were interested in trying to find out what people's immune system was doing when they'd had COVID and then developed long COVID. What was their response to the COVID virus, and what were their antibodies doing? Because that might help us understand the timing of their long COVID diagnosis and perhaps some of the variants of long COVID, that cause that. And then we could try and treat those variants. And there are new medicines becoming available, which may help us to treat these sorts of more severe presentations. One of those medicines groups is monoclonal antibodies, so synthetic antibodies, which help your immune system to attack and take away the virus out of your body. So that's the background to this very difficult to treat, very complex condition that really begins to sort of become a chronic fatigue syndrome after some time and can be very debilitating. Now, we're going to try and keep to time today. So we're going to be talking for about an hour with questions and answers. Essentially, I'd love to, first of all, introduce my colleague, Professor Andrew Shaw, to find out a bit about him and his work, and then we'll go into some cases, and we'll have a couple more polls, and then we'll have some time for Q&A at the end. But I think it's really important to note that A, this is a very difficult subject, B, that we probably all have skin in the game. So a lot of the people who are clinicians in long COVID know someone or have had it themselves, and this is a really challenging condition to treat. So we don't take it lightly. It's a huge issue for governments and for individuals around the world, and we want to engage with that and try and move forward the boundaries to help people get better, because that's what we're here to do. So we built a multidisciplinary team at the Dr. Finlay's private practice long COVID recovery clinic. And we can see people online around the world, or face-to-face in the UK, in London, in Leeds, or in Birmingham. And we have a whole team, including doctors, psychologists, nutritionists, and the whole admin team behind that to help you to try and get better. So if you do want to book a test, we'll have some slides later explaining how to do that. I'm going to hand over to my colleague, Professor Shaw, now to talk about the background to his test, and to understand a bit more cases and why this could be a significant thing to help people with long COVID. So, Andrew, over to you.
Thanks, Ben. And obviously, as a professor, I'm going to start with a few slides so that you get to understand a bit of the immunology and that we're all on the same page. So we've done some work initially with this PhD student in my research group. And Attomarker is a company spun out of my research group, so declaring my interests there, but the work is funded in part by the university's alumni. So to make sure we're all here, you get a SARS-CoV-2 infection, the virus goes in through your nose and it binds to these ACE2 receptors inside your body, and that gives you acute infection. You start getting all the symptoms of flu, loss of taste, all those early symptoms that we understood. And that on goes for a while, and for most of us, we get rid of the symptoms, we get rid of the disease, we shake it off after 2 to 4 weeks or so. And then this 12-week limit has been introduced by various people, including the WHO, and this suggests that post-acute sequelae take over, maybe in your lungs, maybe in your digestive tract, your heart, your brain, your liver, leading to all sorts of symptoms, up to 250 symptoms, of which you are obviously acutely aware. And what are the possible mechanisms? Well, one is the virus is hanging around, it's not cleared, it's in your gut, it's in your brain, and it's causing microinflammation events, microinfection events, and inflammation. Or you may have developed an autoimmune response to it, a hyperimmune response to it, and that's possibly one of the mechanisms that we're going to explore. So 2 mechanisms there, and that results in your gut having all sorts of problems around it working properly. So thinking about how you might change your symptoms, early wins might be your gut improving quickly because gut function is being restored. So the interesting bit here then is this is the virus. You all know this virus. It's about 90 nanometers in diameter. This is the spike protein. And this guy is the protein to which we make antibodies, whether via infection or via vaccination. And so this is the famous spike protein here shown in blue with all the bits from the initial Wuhan variant, but now with all the escape variants all the way up to KP3. And this bit docks onto receptors all around the body. And I think that explains your symptom set. It binds this ACE2 receptor in your gut, in your brain, in your heart, in your lungs, etc. 250 symptoms. So if you didn't get rid of it, all of these low-level inflammation events could be caused by spike protein or by the virus binding to different receptors around the body. So how do you normally get rid of it? Now, here's a piece of science that's quite tricky. The antibody that's effective binds the virus, and it's got to stay there. If it sticks, then all these other mopping up processes occur. This is what clears the virus from your body. So if you're unwell, you make good quality antibodies. The antibodies go to every corner of your body, and they bind to the virus when it's there, and they need to hang around. They need to stick for a bit. And in the process of sticking, they then, for about 2 hours or so, that complex works, and then the body then clears it, takes it into the cells or the other parts of the immune system. So we invented a test that looks at the antibody concentration that you've made to a spectrum of variants, all the way from Wuhan, Alpha, Delta, and this spectrum goes up to XB115. But if you've had the test recently, it goes up to KP3, and we're about to put XEC on it. But the novel bit for us is to measure the quality of your antibodies. So not only do you have enough antibodies, but are they going to hang around for this 2-hour time window? So this is a good response, good, nice concentration of antibodies and good quality. 60% of them are going to hang around for the 2-hour period that we think is important. But the long COVID patients look very different. And this is the good response, again, good quality antibodies and good quantity of antibodies to the variants. But if this long COVID patient here is really missing good quality, concentration of antibodies across the spectrum, and none of them are good quality. Some really poor quality antibodies, very low production. This patient is immunocompromised in some way. This patient over here may be producing large quantities of antibodies. This is about 4 times the average vaccine response, and we've seen it well above 200. And so there's a group of patients that are also hyperimmune. About 65% of patients are immunocompromised. About 10% of patients are hyperimmune, leaving about 25% in the middle where my test isn't really providing a difference. So Ben, the challenge is if you see a patient presenting with an antibody immunity spectrum like this, you have got to turn my crazy piece of science into something that's a bit medical. So where do you start with a patient with this sort of spectrum?
It's a great question, Andrew. So I think what I love about the test is it adds a lot of detail to the timing of perhaps a gap in the immune spectrum, but also the kind of the quantitation. So you get a feel for perhaps how immune compromised somebody is, and also understand the timing, which potentially may be the last variant they've had, which then has hung around because they haven't produced strong antibody response to it. The challenge is the patient who has this autoimmune reaction, whereas very high reaction to some of the variants, and they are probably the most difficult patients to treat. If we're looking at a complete gap in the spectrum, then the science would lead us to believe that there's no antibody produced or very low level, and that it's not good quality. So it's not exiting the COVID spike protein or the COVID virus from the body effectively. It's not targeting it. So these patients, as you say, have immune compromise, and some of them have multiple co-infections. So they might have other viruses like Epstein-Barr virus, which are known to reactivate when people are immune compromised. They may have other bacterial infections that are causing the immune compromise, or chronic illnesses which leave them open to immune compromise. So it's really a very complex picture now, and this is really helpful in terms of identifying those people with an issue with the COVID virus itself and persistence, either of the spike protein, so they're still producing lots of spike protein, in which case we'd want to try to degrade the spike protein that they're still producing. We'd want to try and get that off their receptors, and there are some novel ways of doing that. We might look at things like medicines like ACE inhibitors that can bounce spike protein off your ACE receptors, or things like nicotine patches that might bounce the spike protein off your nicotine receptors. But ultimately, we've got to try and identify and treat live replicating virus, because COVID doesn't have a latent phase. It's either there, present and replicating, or it's just debris, which could still irritate your immune system.
So how useful is the presentation of symptoms when the patient arrives? And then what else do you do to sort of work them up to look at EBV and other options?
Yeah, it's a good question. So essentially, as you said, there's so many symptoms that can be presenting with a post-COVID or a long COVID presentation. Typically, we would see fatigue. We would see things like brain fog. We may see pain. We may see neurological symptoms such as light sensitivity, or problems with various systems. The gut being a big one, the cardiovascular system being a big one. So we assess the full breadth of those systems at the first appointment, both with a questionnaire and with full sort of background of blood testing that has been done. And we look at the full picture. We're looking in an integrated way, and we have an integrated team. So the nutritionist is involved, the psychologist is involved, the doctor is involved, and we're trying to pull together a really broad picture of where which systems are being affected. We then try to stabilize the patient as much as we can, because a lot of patients are very unwell at that point, and there are some things we know that can help them achieve stability. So often we find that patients have a lot of MCAS, or increased allergic responses. So we can dial that down with things like antihistamines on a basic level. But we've got to work out which part of the body is affected, and some antihistamines can penetrate the brain, like ketotifen, for example, which can be really helpful in dialing down to neurological or brain-related issues. And then we're also looking at the gut and the gut biome, because we find that COVID uses up a lot of the bifidobacteria, and so that can really help us to then, in a sense, kind of stabilize the system. We want to have a good, stable system and trying to promote increased immunity, whilst dialing down inappropriate overreactions like autoimmunity. And a lot of those autoimmune reactions are driven by co-infections, maybe bacterial or viral. So we might use antivirals against something like Epstein-Barr if we've tested and found that, and there's a symptom set that goes with those sort of virus reactivations. Or we might find things like reactivations of Lyme disease or Bartonellosis, which are sort of chronic bacterial infections that also do require treatment. So essentially, we're trying to dampen down the system to calm it down if it's an autoimmune reaction or an allergic type presentation. We also need to promote good blood flow. And we know that there's a microclotting theory behind some presentations in long COVID. We also test for polymorphisms like MTFHR, which help us to understand if some people are more likely to be more clotty. And for those people, we might consider anticoagulation, right up to things like apixaban, sulodexide to help thin their blood, and perhaps as simple as herbal things like ginkgo biloba or nattokinase to help sort of move the blood along and get better perfusion of organs and better oxygen transfer, because we know that the blood vessels are affected. There's an endotheliitis, an inflammation of the blood vessel wall that then keeps this sort of inflammation going with long COVID, and that would be caused by spike protein.
And so how many patients arrive in a fairly unwell state that you can stabilize even before you begin to think about how we might repair their antibody spectrum? And I'm thinking particularly about the 35% that I can't tell a difference for, or we know that are generating large numbers of antibodies that are autoimmune.
Well, we're actually researching our own database because we've treated over 1,000 patients now. I've got a student working on that question as we speak, and I'll be able to give you some differentiation of our patient group fairly soon in hard numbers. In reality, we have a whole spectrum of people presenting, from younger people, and I now mainly treat children, and right through to older people. I'd say the most common sort of age group is probably sort of 35 to 50. Working age people who can who's had a big impact and who are seeking to be able to continue their lives, or people who are so severely unwell that they can't attend clinic, and we're seeing them online or seeing their carers online. So we try to baseline this whatever way possible. We do also use blood tests and remote technology to do that and to review those. And then we're really going to try and set in motion an anti-inflammatory plan to help that patient stabilize. But then we need to think about treating the causes. It's all very well to treat the symptoms, but you need to treat the underlying causes that drive, what's driving this chronic fatigue presentation, this post-COVID syndrome, what's driving the gut problems, what's driving the neurological problems, and treating those underlying causes is key. So part of that is COVID, and it's still circulating spike protein. Some people have had tests to demonstrate they still have COVID activity going on, either from a recent infection in the last few months or from they're harboring an infection in a reservoir somewhere. And so antivirals like Paxlovid can sometimes dial down that actual replicating virus. We've tried that, and in some people that's worked well. It hasn't worked well in everybody. And so we're still learning about which treatments may work on some people. And sometimes what you'll find is you'll treat one item, but another one will pop up because actually it's more dominant. So we often find the bacterial things, if left alone, actually will keep dominating, will keep causing immune suppression. Things like Borrelia or Lyme bacteria are particularly immune suppressive. And if you don't deal with them, even though you've dealt with COVID spike protein and COVID in itself, you might still have a chronic fatigue syndrome with neurological presentation at the end because you've got another thing hiding under the thing you thought was the cause. So we have to kind of take a full comprehensive view, and it is a slow process. Some people do also respond just to natural, nutritional improvements, gut biome work, but actually we're able to help most people in some way to improve their symptoms while we are trying to investigate the actual cause of their deterioration at heart. And I think that leads us to the spectrum and the monoclonal antibodies, actually, because for COVID itself, we don't have many options for treatment. Around the world, the US has invested huge amounts of money in trying to understand this. In the UK, we've been rather slow at having research, and the results aren't in yet. And often they're things that we've already tried and haven't worked. So MABs really came to the fore, I'd say. Last year, we really thought that things like Evershell might be a useful intervention for people who had COVID persistence. And we were trying these things, but we didn't know who was going to be a right candidate. And enter stage left the Attomarker test, which helps us understand, right, which variants do you have? Which variants are you likely to still be retaining? Ellie, I don't know whether you can pull up the slide of this just to help us understand this sort of scenario. So, what the test helps you to give is an understanding of when the person became unwell. This is a slide demonstrating different waves of the different variants that happened from 2020 onwards. It stops in August 24, but actually we've had about 3 or 4 variants since then, Andrew will tell you. And when we superimpose the Attomarker test on this, you can see at the bottom of the slide here, the different variants that this particular patient had, and understand what the timing of those was and whether that related to the onset of their long COVID. Interesting enough, we've had patients who have tried early variant monoclonal antibodies and some have worked really well, and some haven't worked at all. Now, we didn't know until we had the Attomarker test why it wasn't working, but we had another patient in whom they had taken Evershell, but actually their profile of immunity was very poor to the Omicrons. Now, Evershell doesn't treat very well, the Omicron variants. And so, no surprise, this patient took Evershell before they'd had an Attomarker test, and Evershell didn't make a difference at all because they had late variant problems with their immune system. The early variants they'd had a strong autoimmune reaction to, so they didn't need more antibodies for that. They already had them. They were producing their own. So I think what's really helpful with the test is it differentiates the groups and then helps us to determine who's going to be treated, because monoclonal antibodies are very expensive and difficult to get hold of. And we want to make sure we're treating the right person with the right medicine.
I like that, because even the negative result is confirming the accuracy of the test. Ideally, you want a positive result, but to know that somebody had a late variant and we tried to treat it with they tried to treat it with an early variant monoclonal, proves the chemistry, proves the science behind the process.
It is, and this is the fusion of sort of science with medicine. And this is a really sort of cutting edge field. Now, as a GP, traditionally, I wouldn't have got involved with this, but as I've got deeper and deeper into long COVID, I've been drawn into trying to find solutions for these very complex problems. And I work with very clever people like yourself who understand the science, and then I try to put it into practice. Now, I think another really interesting case is one of our patients who is a young lady in her late 20s who's had a really difficult time with long COVID, and who was successfully treated with a monoclonal antibody, sotrovimab. And this was earlier this year. And what was interesting about this patient was that she'd had a really challenging. Oh, sorry, just go back to the slide for that's the steps. Yeah, really challenging presentation with really severe post-exertional malaise, which obviously for you patients, you'll know what that is. For those of you listening, it's a severe reaction to overexertion or to exertion, and it could be cognitive exertion, could be social exertion, could be physical exertion, or even emotional exertion. And she was very much limited and perhaps only doing about 500 steps a day, which, if you've measured your steps, is really pottering from to and from the bedroom to the bathroom and back again, and maybe eating a meal. So it's a very, very small amount of steps. And if you can see on this graph here, between the 10 and the 17, she was doing a very few steps, maybe about 500 steps. Now, at that point, she then had an infusion of sotrovimab, and sotrovimab at that point was the monoclonal antibody we had available. She had tried Evershell before and had a mixed response, a beneficial response to the first infusion, but then no benefit since then. So it looked like we dealt with her early variants with the Evershell, but she still had a problem with later variants. What we noticed was the first infusion, she didn't really have much effect at all, but the second infusion, which bumps up the level of antibodies significantly, almost overnight, her step count went from 500 a day to 1,500 a day, which meant that she actually got out of the house for the first time in months, which for her was a massive improvement. She was able to see friends. She was getting up and about. She was doing so much more, and that was a massive shift that we can attribute to that infusion, because there was nothing else that we did at that time. She also noticed an improvement in acne, which completely cleared up, which is very interesting. Interesting enough, she also reported no PMS after the infusion for the first time in years. So there clearly was a significant effect of the sotrovimab. Now, in her case, we also tried to use the ACE inhibitors to bump the spike off the receptors, and because sotrovimab works better on free spike rather than bound spike. And this is all fairly theoretical, but it means that we want to try and target the available spike protein that was free floating. So we tried to make it more free floating, release more. So again, we were using ACE inhibitors.
Recovery is an interesting question here. This we've also seen a patient who had an antibody test before an actual infection and got an infection. Her antibody spectrum improved and antibodies to the persistent variant were made.
Yeah.
And she was in a wheelchair and got up and started moving around within a week, back to work, on the train, etc. How fast do you think recovery is likely to be?
Really good question. It's very variable, and I think there's a lot of genetics here. People's genetics really do seem to determine their speed of recovery. A very difficult combination here is the genetics of people who are hypermobile or have family members who are hypermobile, And I'm sure a lot of the patients listening will put your hand up and go, yeah, that's me. And that's also me. I'm very stretchy. I've dislocated my knees. I've never broken anything, but I've dislocated a lot of things in my lifetime. And so hypermobility seems to predispose us as patients to a vulnerable immune system with this boom bust sort of poor response. And the genetics of that also predispose us to autoimmunity and this allergic type response. And that's the hardest one to treat. And I would probably say we're in the group who get the most severe symptoms because we don't get much of an immune response to Omicron group particularly. And so I was fortunate to recover over a period of 3 to 6 months with all of my knowledge and everything focused on trying to get better early on in 2021. And then we went on to treat lots of people who hadn't recovered. But I think the more severe end have multiple co-infections, and they will take maybe 6 to 12 months to recover on the right treatment, because it's not just getting rid of the pathogen, the COVID. It's rehabilitating the body that's been ravaged by this sort of neurovascular problem and all the complications that come with that. POTS, the retraining of the nervous system, the neurovestibular rehab that has to happen. All of my muscles wasted away, Andrew. I used to lift 140 kilos. I couldn't even lift my son or even a log when I was poorly with long COVID, and that took time to come back.
Right. There's a question asking which ACE2 inhibitor we used in in your combination therapy of this patient.
That is a great question. We used telmisartan because there was a study in pigs that telmisartan had conferred some protection against acute COVID, and it was thought to sort of protect your ACE inhibitor, your ACE receptors, as an ACE inhibitor. So we tried a very low dose of telmisartan in this particular patient, and we have found it anecdotally to be helpful in some other patients at low level. It does require monitoring. It is a prescription medicine, but that was quite helpful for some patients. It may be an ACE class effect, so there may be other ACE inhibitors that work just as well. We haven't tried multiple different ACE inhibitors yet, but there does seem to be a protective effect of ACE inhibitors. And other things we've also found is a protective effect of things like metformin. So metformin has also been postulated as an anti-inflammatory theory. It seems to improve gut wall, and we've used it to some benefit in some patients with long COVID, and that seemed to be a protective thing when people had acute COVID. If they're on metformin, they actually seemed to be more protected than people who weren't, which is bizarre because we would have thought that type 2 diabetics who were on metformin would have been far more vulnerable.
One of the symptoms that's quite prevalent is brain fog and effects with cognition. Can I quickly look at some data from a patient that we gave Evershield? Because as you can see, this patient here had a poor antibody spectrum, missing the good quality antibodies for Wuhan. And somebody's asked in the questions, what does a normal spectrum look like for somebody who's only had a Wuhan infection? And it looks like that. It means you've made good quality antibodies often to the early variants, but then you've made it to nothing else. So this is called original antigenic sin. You make a good antibodies to your first exposure. You store the recipe from that, and then whenever you see the virus again, you keep making the same recipe, even if it doesn't work. And Evershield is effectively that. But in this patient here, we plugged the gap with Evershield, and the patient was bedridden, migraines every evening, hadn't been out of the house, as you'd said. And after the first infusion, the antibody levels rose quite nicely. After the second infusion, I was suggesting scientifically 3 infusions, because that gets the antibody level up quite high, which means it pushes around the body, into your brain, into your gut, everywhere. The gut function improved really quickly after the first infusion. That's accessible. Be fairly easy to remove the virus from the gut because the blood is prevalent in the gut. But the patient was feeling so much better, they went on holiday for the first time to Greece, so ruined my time course data, which was a bit frustrating. But the bit that is rare, very rare, is this is what the antibody concentration looked like in their serum, in their blood. And you can see it's quite high, but we also managed to get some measurements from their cerebrospinal fluid so that it crossed the blood-brain barrier into their head. This level is very rarely seen for antibodies, and it led to the improvement in their cognitive function. So coming back to my idea, the virus might be persistent in every nook and cranny of your body. you really do have to get the antibody concentration up sufficiently high to perfuse even across the blood-brain barrier into the head. And I think this is quite an important observation, and it's not been seen before, and we'll publish this shortly.
I think what's really interesting is anything that enters the brain and the central nervous system and crosses the blood-brain barrier really creates a lot of problems with neuroinflammation, and a lot of the longer complications of long COVID or post-COVID syndromes, and indeed chronic fatigue and ME presentations, are neuroinflammatory conditions. We see all sorts of problems with nerve signaling. Most people will probably be aware of the vagus nerve, which it supplies the diaphragm, the gut, and some of the heart, and is a big highway from the gut-brain link, and that's certainly affected, and does a lot of automatic processes managing blood pressure and things that you don't think about, like breathing. And those nerve bundles seem to be severely affected and by these kind of conditions. So reversing that takes time, and it takes time for those things to heal. So I see some of the questions are about various anti-inflammatory strategies, such as coenzyme Q10. One of the questions here is about a person who's trying to find answers for their daughter, NMN, and some of these things can help improve the inflammatory status. From our large amount of trying to help, well, both myself and lots of other patients, what we found is that anti-inflammatory strategies are really helpful. So high dose vitamin C, things like high dose vitamin D are anti-inflammatory, antioxidant. Then coenzyme Q10. All these supplements can help, but ultimately they might dial stuff down, but they won't treat the underlying cause, because ultimately, if you've still got a pocket of bacteria or virus that's still affecting your immune system, then you might kind of help upregulate your immune system, but you've got to deal with the actual the pathogens themselves. And that led us into the area of chronic Lyme disease and other bacterial and viral co-infections. So we see people having reactivations of chickenpox, reactivations of Epstein-Barr, which is very commonly carried in the European population. And those things you can't get rid of. They're herpes viruses that live in your nervous system and will reactivate if you're low. So it's important to maintain that nutritional status, antioxidant, so anti-inflammatory status, but actually you've still got to treat the underlying cause. And so all these strategies are useful. And in some people, it's enough to tip the balance back into a healing response. Other strategies we found, like red light therapy, which can be get from sunlight or from machines, can also really help boost your immunity, boost your mitochondria.
Somebody's asked here, how many people that have recovered based on the Attomarker information? And across all of our clinics, I think we have intervened on 6 patients, plus the patient I mentioned who had the natural infection. 4 of them had Novavax, which is sadly not available at the moment, but is the FDA are reviewing. So hopefully that may become available again soon. And 2 have had MABs, including the one you mentioned earlier. Of the interventions based around the Attomarker test, everybody's got better and shown significant improvement. What does better mean, right? They're getting better, they're feeling better, they're beginning to return to some sort of improved life. We're urgently trying to get hold of Sipavibart, which is the AstraZeneca pan variant antibody, which we think we want to trial on a few people. It should work scientifically. We just need to get hold of the drug. Do you want to say a bit about the availability of Sipavibart and the trouble we're having?
Well, I think what's sad is that partly, well, we're based in the UK. We do treat people across the world online. However, a lot of our patients and maybe some of the people online here today will be based in the UK. Now, the UK left the EU, unfortunately, which meant that we didn't have easy access to EU medications we used to have access to quite easily. There's no import rules now. So things get stuck in customs. And we've had real problems trying to get MABs into this country in order for people to be treated on a named patient basis. Now, we're not talking about mass treatment. We would want governments, and if anyone's listening who has the ear of the government in the UK, we would love them to invest in identifying and treating people with repairable immune spectrums by doing a test and then by using things like MABs to get them. But we're talking on a named patient basis, which is an off-license use of a medication in people who are immune compromised. But it's very hard to get hold of the medication. One of my patients had the ability to track this down around the world. So her husband went off around the world and managed to find 3 doses of sotrovimab, but most of us can't do that. And so we're trying to get these in through the EU to try and treat people, or even have people treated abroad if they can travel. A lot of our patients are that poorly they can't travel, or travel might cause a significant problem with their health. So we need a solution to get MABs into this country. We used to have Eversheld available. That was fine for the early variants. Eversheld 2 was supposed to be coming. That seems to have been put on hold. What we're really struggling with is that there isn't a will to get these sort of things like Novavax, which could be really helpful for some people, or MABs that could be really helpful for some people, into the country so that we can treat people. We're desperate to try to treat people who are interested in getting treated. The challenge is getting the actual medication here.
So somebody's also asking about whether the government is going to be interested in supporting it. My hope is that if we can get intervention with a small number of patients, and we'll write it up quickly. So I mentioned the 7 that we had before, but also if we could get a few more interventions around Sipavibart by treating abroad in some way. Also, there's the PEMGARDA trial going on in the States at the moment, which is another MAB trial. I think we need to get a little bit of data together to show that it might work. And at that point, hopefully we can write a grant application and run a full trial for it. But it's going to be slow to get the NHS to agree to something. It's going to be 3 years funding it, and then they might recognise it as a possible intervention. So 3 years on already a 5-year long COVID journey is not very attractive.
I'm looking through the questions here as well, Andrew, and seeing, various people have had real challenges with, being pushed into, graded exercise, that kind of thing, by well-meaning but inappropriate clinics in the past. I do think it's possible to recover from that kind of crash that you end up in. It takes some time, but you can retrain the body, the mitochondria, the support systems to slowly get back out of that hole. And I have seen people, recover from really severe crashes where they're bedbound for many months. So don't give up hope, because I still believe everything is possible to improve. And most of our patients have had some improvement in their symptoms and in their trajectory and their function. Otherwise, we wouldn't be doing this. I had to get better myself. I've got a young family. I'm running a national company. I was desperate to get better myself. And I know lots of our patients are too. So there are things you can do to help. There are things that you should avoid. And exercise when you're unwell is definitely a bad idea. As an ex-triathlete, I used to think exercise was the best medicine, but I wouldn't recommend it for most people. When you do, you really have to be careful. I'm actually producing a little course about how to re-engage with exercise safely, because confidence is something that we lost as well. But you might find physically you're better, but you still don't have the confidence to exercise. So you've got to do this carefully under supervision. We've got a great physio who's helping us with pacing in the clinic, who's helping patients online to kind of build these plans wherever they're at, just to start off with something as simple as, okay, we're going to do some stretching in bed, we're going to do some leg raises, something really simple, right up to let's walk around the room, let's begin to walk outside the room, let's walk briskly, let's try and walk upstairs, let's try and go for a walk outside the house. So it's all slowly improving if you can, but you've got to do that at the right time. You've got to try and maintain muscle mass as well.
There's another question here about somebody's already had the Attomarker test about a year ago, has been sick in the intervening period and is waiting for treatment, and whether they now need another Attomarker test. Scientifically, I'd like to see what changed. It's possible, for example, that the later variant infection has improved your antibody spectrum, but if your symptoms haven't improved, my guess is it didn't change anything and you continue to make the poor antibodies. What's your feeling about that? A long gap between the tests, is that something that needs repeating?
Very good question. I think that the question is, what's the, we always ask ourselves as clinicians, what's the point of doing a test? Is it going to change the management plan? So is it going to change the outcome for the patient? Otherwise, there's no point in doing a test unless you're doing a trial, in which case it's an academic interest. But I think the question is, has enough time elapsed to see whether there's been a change in the patient's immune spectrum, or have they done an intervention that might help them to demonstrate an improved or a changed and altered immune spectrum? And if there is, then it might be beneficial to repeat the test. And actually, Andrew, what we're trying to do with our pilot group study with MABS would be to have at least 30 patients who have a pre-test and then a test after they've been treated, so that we know, right, have they been treated? Have they changed their antibody spectrum? If they have, then that would really help us.
Yes, if I could make the scientific link between recovery and the antibody spectrum. There's some new research going on in the lab at the moment where we're looking at subclasses of antibody, IgG4 and IgE. I'm hoping that IgG4, which is usually the intolerance subclass antibody, it's elevated or appears to be. We're going to publish this shortly in long COVID patients, but it could go down if the spike protein disappears. So it could be a marker of recovery. For me, that would be evidence that it's been removed from the body. It may not follow that the symptoms recover quickly, because there must be some risk of damage if you've been exposed for some time.
Yeah. And I think the damage bit is interesting, because I think some of this is reversible. And I think I've always been a firm believer that you know, doctors often say to people, oh, that's shot, you're shot, you know, your knees are shot, says the surgeon, you can't do anything about that. I've never accepted that. The body's amazing at regenerating if given the right nutrition, the right environment. And I do think it's possible to actually to reverse some of these damages. Some things have become permanent if they've been too long, but the endothelial damage, you know, to the blood vessel stuff, we have seen reversing some people. People, amazingly, I mean, the typical thing is you get really cold hands and feet when you've got long COVID, and you'll all be nodding your heads at home. What's amazing is when someone recovers, their hands and feet go back to normal. I turned back into a radiator, and that was, you know,
you don't need biomarker chemistry, just measure the temperature of your hands. And right.
It could be a useful thing. So I think another question here I've got is about augmented NAC, which is so NAC, N-acetylcysteine, used to be used for people who'd had sort of poisoning, maybe with alcohol or other things, and it protects the liver. That can be really useful, but it's also a biofilm disruptor. So it helps break down biofilms that bacteria can produce. It breaks down their sulfur bonds and allows the immune system access. So if your COVID is highly in a biofilm, that might help. It also is supposed to break down spike protein. So yes, I do find augmented NAC useful, and I'd recommend considering it as part of your medical plan under supervision.
Another question here is asking if the Attomarker test is available internationally. I'm excited to announce that next week we should receive the first samples from America. So yes, we know how to ship from the EU. There are 40 samples coming over from America. I think with a little bit of cleverness on our side, and maybe with Ben through Dr. Finlay, we can start supporting patients internationally with teleconsultation. So hopefully the test can be collected internationally. And the other question that follows from that is, do we know where in Europe where the MAB is available? So I have an answer to this. Technically, it's available in places all over Europe because it's been approved by the EMA. It turns out that in chatting to a clinic in Amsterdam, they were going to struggle to get hold of it. And I was chatting to somebody in Rome the other night, and he thinks it might be difficult to get hold of, but under a trial is possible. But we're looking for European partners, and I'm working hard for that with the idea of introducing the test through Ben to act as a remote site for us. So yes, it's complicated.
Other questions we've got are, someone's asked, am I fully recovered? Am I fully able to exercise? Well, I'm working full time. I'm able to exercise fully. In fact, my brain feels better than it has done in a long time. I did have a relapse last year when I got Epstein-Barr reactivation, interesting enough, but I've fully recovered from that as well. So I think I've always been an optimist, but I do believe it's possible to recover from these things. We've seen remarkable recoveries from people who are very, very, very poorly in our clinic, and so yes, I'm probably lucky. I may have good genes and maybe got in there early with an antioxidant, plan and gut health and things, which I think helped me recover quicker. Should we do a poll, Steve? We wanted to ask how many people have had an Attomarker test who are already on the on the call. We've got about 100 people still in the call, so it'd be really interesting to see have you had an Attomarker test if you're here in the webinar. Okay, it's interesting seeing these results come through. Here we go. Okay, so we have a good audience participation. So thank you so much for engaging. It's great to have such excellent engagement. 82% of people have responded. Thank you. So interesting enough, we've got 92 people in the room, and 29% have said yes, they've had an Attomarker test, and 71% haven't. So that's a really interesting statistic. So bearing in mind a lot of you are patients, it might be worth something considering. And at the end, Ellie does have a slide about how you could go ahead and book an Attomarker test if you wanted to. We'll put in the chat the link for how to do that. In fact, Ellie, do you want to stick that in the chat now, just so that people can sort of have sight of that?
It's in the chat already.
Oh, fantastic. Thank you. Thank you. I can't see the chat at the moment, so I'm looking at different things. Okay, so
there's another question here that worries me. This is from a father whose daughter has had long COVID for 4 years now, and the child is now 14 years old. The bit that worries me, and I have to speak like a scientist here, but my young children are growing up, and I can't help but think that the growing chemistry, which is really important to them, they're growing inches each year. I can't help but think the growing chemistry is going to be affected by the presence of the virus. So that's a very scientific response. What's your feeling about children and long COVID and the long-term outcome?
It's a great question, Andrew. So as a GP, I used to look after children as part of my family doctor practice. When long COVID came along, I started treating adults. And then what I found was a lot of adults were saying, can you treat my child? I've got long COVID, but my daughter has too. So I ended up actually sort of subspecializing into treating children, because not many people have actually been able to treat children in this country. The NHS has sort of downregulated a lot of long COVID services, and children are really suffering. Children are quite challenging to treat because they're not mini adults. It's not just a case of halving the dose of things. But the good news is that children do respond quite well to some of the things that we have tried. And when they recover, children recover faster than adults. So we actually see some really heartwarming improvements in children. What we're finding is that the genetics are really interesting here, and there's definitely an inherited sort of risk factor here. We're seeing people who were born by cesarean section more at risk of getting long COVID, and that may be a gut biome issue. They're not developing a full gut biome. We're seeing people who had problems in early life with infection and perhaps had lots of antibiotics also having some more problems with developing long COVID, and particularly children. We're seeing children who have neurodiversity overwhelmingly in our clinic, and there seems to be a strong link between neurodifferent presentations of children, and I suspect that's a neuroinflammatory aspect that is triggered by COVID and made worse. So actually there's a subset of children here who are the forgotten children in the UK, who are disappearing from school, not being seen, not being treated, not accessing treatment, and we're trying to reach out and help. They are difficult to treat. It's very hard to get medicines, very expensive. Oftentimes children have to take liquids, which are expensive. It's quite hard to get things. A lot of things are off license. A lot of things have not been tried and tested in children. So it's a very difficult area.
The children are a real problem. So even running a clinical trial in a child cohort can be very difficult. Same it's like for pregnant women, and running clinical trials for pregnant women is very difficult. We've had a question asking about is there anything that can be done to validate the Attomarker test? Well, it's got a UKCA mark, so I know the test is reproducible. It's doing everything it needs to give you a good quality answer. The bit that needs to be done now is to get the cohort of patients in to show that the antibody spectrum test correlates when repaired with a good outcome. And I think there are large numbers of individual patients who are prepared to pay for their antibody. We've just got to find it for them. I don't know about children. The number of children that have been tested now, but would you recommend they get the antibody, Ben? That's a really interesting question.
I guess the question is, there's no point in doing a test unless you have a treatment available that is safe and effective and you're willing to consider. So I think you have to be very careful to just do a test for the sake of doing a test. Also, the good news is it's only a finger prick, but some of these blood tests are, nasty. No one likes being stuck with needles. So I think, where children are concerned, we try to minimize the testing to the most relevant things that we're going to do. I think if you did have someone with a real typical post-COVID presentation in whom other things had been ruled out, then actually a finger prick test for Attomarker might be really helpful to understand if we think that COVID spike persistence or live COVID virus persistence is the main driver of their condition. And that might lead us to then understanding whether what treatments they might benefit from. I just think it's even harder to treat children than it is to treat adults, and that's where we fall down. We need a real consensus across the world about what children could be treated with and how to do that safely. And I'm not a professor of pediatrics, but we need more of those people involved.
The blood test works well on the finger prick, so it's very low risk in terms of the invasion to
Absolutely.
the child, but
Absolutely.
it generates a large amount of data. So I would happily do a heel prick test on my child to collect the data.
And I think as blood tests go, this is one of the more powerful ones. We're not triggering POTS. We're not taking lots of volume of blood. It's probably the least interventional of all blood tests we would do. But I think we have to be careful that we're thinking through that what happens next. And actually, information is useful. What we want to know is right, what's the treatment? Paxlovid, I think I'm right in thinking was only licensed for 12 and above. So various different things have been licensed for things. Now we do use things off license, where the overwhelming case is actually that deteriorating without treatment means that taking intervention that has a known risk is worth doing. So there's a careful decision to be made there with parents and children. And
my feeling here is that it'd be good to get 30, 40, 50 interventions in adults. And at that point, it becomes a justified risk in the way that you're saying, Ben. Scientifically, it's as good as we can get, I think, in terms of evidence. Then it's down to the clinical judgment to make it work.
Yeah, absolutely. Someone's asking who in the practice is able to provide treatments in response to the Attomarker results. The answer is we have a trained group of doctors who have specialized in this area over many years, led by myself, and we're able to then issue treatments on a named patient basis from our London clinic or from our Leeds or Birmingham clinics. So we can see people online from around the world. We don't see people in America, unfortunately, because of the high risk nature of the legality. But essentially, we can see and treat people, and there's lots you can do from home with our support. You'd be surprised what we can do. I think what pandemic did teach us was actually how to treat people remotely and safely and effectively, and that's a real shift in doctoring from face-to-face. There's nothing like a face-to-face consultation, but when someone's really poorly, bringing the consultation to their bedside is the next best thing.
And somebody's asked this question, can they get the test remotely? Absolutely. The protocol is that you request the test to the doctor, and we then send something out by mail away, and you do the finger prick at home. We track it back, and we give the test results to the doctor in a couple of weeks. At that point, a teleconsultation is the recommended route forward with you, Ben. And you're right. I think even treatments could happen at home at the right time. I think a vaccination, for example, with Novavax could happen at home.
Yeah.
But maybe the first jab of the monoclonal could happen at home as well.
We've had a lot of questions about how to book an Attomarker test and the logistics of that. Ellie, can you bring up that slide about how to actually book? And we'll just talk through how it actually happens. It's pretty straightforward. If you want to book one, you would contact our clinic. We would arrange for a kit to be sent out to you. And then essentially the kit arrives in the post. It's a finger prick test. You've got to do it in a controlled way. There are instructions in the packet. And then you send off a little tiny vial with 10 drops of blood, I think, Andrew, which I did to myself. So, like all good clinicians, I want to see what my own results are first. Yeah. And then we send that off. It's anonymized. So Dr. Finlay's would retain the patient information, but Attomarker have anonymized information. It then takes about 10 days, 2 weeks to be processed. And Andrew, you might say what happens when it arrives in the lab?
So when it arrives in the lab, we separate it quickly. We check the quality of the sample. If it turns out that it's been forgotten in the letterbox somewhere, or you've sent it over the weekend, we have to decide whether it will run, and we do that immediately. If it doesn't look like it's going to run, we'll send out another box or request that to be sent out through the clinic. Then it's spun down, and we run the assay twice over the different variants at different conditions to give you the quantity and the quality, and prepare the report and send it back. So it's a fairly straightforward test now because we've automated it with its UKCA mark, and it's very reliable.
Yeah. So this is how to book. So click the link in the chat, get your home test kit, jab yourself, send it off to Attomarker. Then you receive your results, and when you've booked a test and consultation. So then when the results are back, you would then see one of our team at Dr. Finlay's online to discuss your results and understand what your particular, personalized antibody spectrum looks like. And then you can work out from that whether you'd like to take it further forward to actually go into a consultation and arrange some treatment or see what your management plan might look like with Dr. Finlay's. And we're really very well versed in doing this. And Andrew, how many tests have we actually done so far over the last sort of 6-9 months or so? Do you have a rough figure on that?
Dr. Finlay's has done about 150 tests. Across the entire project now, we've probably done more than 450 tests. And the diagnostic publication, which is coming out soon, works really well. As the number of patients goes up, the quality of the diagnostic information is really improving. So it means, I think, that even if you're part of the 65% waiting for the MAB or the vaccine, 35% of people could get treated straight away using your treatments for hyperimmunity and the unclassified patients. Yeah. So I think it's for me, if I were suffering from long COVID, I'd want to know what to do, and I think this is a way forward. Now
we're coming up to time. I'm just looking at the clock. Steve, I think you've got a final poll to do. Do you want to just put that one up just for interest's sake while we're finishing? Now, we sometimes go into extra time. There's so many questions here. I think we could talk all night. We'll have to try and pick up a few questions in the last few minutes. We may be able to extend another sort of 10, 15 minutes. But here's a question. So after hearing the webinar, would you consider booking an Attomarker consultation and test? And let's just see what the results are coming through. So quite a few people looking like maybe, a few no's and a few yeses, quite a strong amount of yeses. So we've got, again, 80% participation, which is really great. Thank you. So we've got 60% would go ahead and book an antibody test. So it's great to hear that you understand what the test does and what we're trying to do. And so please do use that link. If you're listening to a recording of this, then please do go to our website at drfinlays.co.uk and you can book a test there and consultation online. So if you don't have access to the chat because this is just a recording, then you can please do that. But actually, overwhelming majority, 60% wanted to book a test, 34% maybe, and 6% said no. So I think it's a really good response to the science behind the medicine, Andrew. So thank you for providing this new test, which is really helpful.
There's one question here I quite like, which is somebody says they've been infected 7 or 8 times and asking whether they should isolate. 7 or 8 times is a large number, and scientifically I'm intrigued as to why that happens. And there's options around testing the antibody spectrum, of course. Yeah. And it's maybe they're not making good antibodies, but I'm quite worried about whether they've got good T cells, and there are T cell assays looking for how well the T cells respond to the messages. And so maybe the person concerned is doubly immunocompromised. I think that's something that you could follow up easily.
Actually, interestingly, Andrew, I think I've had 4 or 5 infections myself. So I haven't actually confirmed this, but I think I had my first infection in October 2019 when I saw a patient who'd come back from Wuhan on a business trip. And I was then very unwell for a month with a strange virus chest infection. And then I got Delta in December 2020, and I got Omicron, one of the first Omicrons in December 2021, and then I got COVID again last year. So I've had multiple infections myself. It turned out the reason why was actually I had underlying Lyme's disease as well. So actually that was suppressing my immunity. And I think with this sort of patient, multiple infections, you've got to ask whether there's another thing driving their low immunity.
Yes.
And often that's a bacterial co-infection or chronic other viral presentation. Let's just a few more tests and questions here. Okay. Yeah. Okay. So some positive response from John Fulbright, who says he feels the Attomarker could demonstrate positive attributes and validate recoveries. And he's been looking into bee venom to recover immune function, which is an interesting angle. I've heard a couple of patients doing that. So bee venom tends to stimulate a massive immune response, but you do it sort of over time, and that can help you regain your immunity. So very interesting. I'd certainly do that under supervision if you're wanting to do that. I don't have experience of doing bee venom myself.
Somebody's asked about the price, which including the consultation is what are you offering it at, Ben?
Do you know, I don't deal with the prices, so I'm just going to look online on my website. Or Ellie, could you actually have a look and just see what it costs to book a test and consultation, just in the background? Thanks. We have a booking system, but I'm not the administrator, so I'll just ask Ellie to see what she says.
The other thing that people are asking is how to get involved in the Simpavibart trial. As soon as we know that it's available, we'll make it widely known.
Yeah.
And at that point, if you've had the Attomarker test and you would appear eligible, we'll recruit you to the cohort, some of which we might be able to pay for through philanthropic donations. Otherwise, you might have to pay for yourself. What's critical is that we will get the cohort written up so that we can share quickly the efficacy of the intervention.
Absolutely. Yeah. So other people are asking, is it available in Europe or not in the UK? Andrew, I think you've said that you can ship the Attomarker test certainly through Europe now. Is that right? And what about worldwide?
So yes, as I mentioned earlier, 40 samples coming in from the States. We're getting samples. We've had samples in from Switzerland and France and Germany. Again, I would like you to try and find a doctor to recommend the test and to manage the interaction afterwards. And in Germany, when we can find the right clinic, there's no reason why you shouldn't get the test and then get the intervention, because the Simpavibart is available over there. So it's about timing now and trying to get the availability right.
Absolutely.
And the price of the test, including the interpretation call, is £325.
Brilliant. Thank you, Ellie. So that would include the test going out to you, the results coming back to you, and an interpretation call with a clinician from Dr. Finlay's online. So people are asking how to access the test. You do it at home. You can then beam in online from wherever you are, and we can discuss the results with you, and then you can take that forwards. Someone else has asked about Dr. Finlay's packages. We're renovating our website at the moment, so we'll be producing a new website fairly quickly, fairly soon. We're reviewing how we provide the service because we know that actually it's quite complicated. So you can book a one-off consultation, but in reality, to actually start a journey of recovery, you need a package of care, which includes various different parts of the process. So maybe the nutrition consultation, maybe some pacing advice from the physio, and we are all traumatized by this, and actually the psychological aspect is really important. Let's not forget that on a psychological level, but also on a physical level, because we know that trauma is held in the prefrontal cortex of the brain and causes high levels of stress hormones to be released, which are themselves immune suppressive. So we must deal with the full aspects of this case, and that's why we work with a multidisciplinary team. So if you do want to get in touch with Dr. Finlay's through our website, it's drfinlays.co.uk, and we're more than happy to have a chat with you about what we can do to help and produce a specific package for you that's going to help you on your recovery journey. It's different for everybody, but there are some common things that are important to include and to check. And if you haven't had various things like baseline organ function bloods, you might need to have them done too. But as I said, a lot of these things you can do remotely. So don't feel like you're stuck at home and can't do things. There's so many things you can do from home. In fact, my own recovery started at home with breath work, with gut work, with various things that I started learning to try and get myself better. So please don't feel like you're stuck. Now, unfortunately, Dr. Finlay doesn't take insurance at the moment because we're not covered by insurance providers. It's quite a bespoke thing that we do, but you may be able to claim this back from your insurer. So if you do book in, you might be able to advise them and then get a refund from them.
There's maybe one last question I'd like to answer is about whether the current vaccines will stop long COVID. If you were to get a long COVID test and show that you were immunocompromised, you could go to your GP and argue that even if you weren't 65 or over, you could go and get the latest messenger RNA vaccine. It's possible that that vaccine could then improve your antibody spectrum, and you could contemplate therefore an Attomarker test, a spectrum test before and after the intervention. With the Novavax intervention, we've recommended 3 vaccinations to get the antibody concentrations up a little higher for the perfusion point I was talking about earlier. So it is possible, but I know that long COVID patients are very wary about taking the messenger RNA vaccine, and I understand why, because the message escapes and it may be a mechanism for vaccine injury. I did have the Novavax vaccine because it's a traditional vaccine, protein vaccine. I think if that can be available again, I think I would do that. So interesting question. I think vaccines can repair your antibody spectrum. We haven't tried it yet with the latest messenger RNA vaccines releases yet.
And can I add a comment to that? You've got to have a functioning immune system to produce antibodies. So if you have a vaccine and you haven't got a functioning immune system, you ain't going to produce the right antibody response, and that's when you start having problems, I believe. So it's not just mRNA; it's also people who are already immune compromised by chronic disease, by co-infections, that we see having major problems with some of the vaccine responses that we've seen. It's not just the immediate vaccine and the problems with clotting that we've seen, but it's actually the longer immune problems that come from that, because they're not producing the right immune response to antibodies or creating antibodies. So it's I think I understand the concerns about vaccines. I do see some people improving who've had Novavax. Some people haven't improved. There was a small group of doctors with long COVID who tried taking Novavax. I think about half of them improved and half of them didn't. So we still need to understand more about why those people are not improving and why the other people did improve. It's another test, or understanding the genetics behind those 2 people and understanding other risk factors. I think differentiating the groups is actually what Attomarker does best, because that really helps us understand who's in what group and therefore what treatment might be helpful. So if you do want to join our MAB trial, which we are getting started, please do get in contact. You can email us at team@drfinlays.co.uk and express your interest. Andrew and I are basically leading the study, and we will publish the data for the initial pilot study, and then a wider publication about the results from our Attomarker tests and outcomes from treatment, and then hopefully roll that out to a much wider population. Now it's now getting close to I think time when we probably should finish. We've got so many questions, and I just want to thank everyone for. We've had 89 questions tonight. That's almost one for every participant who's still present. So, and I'm sorry we're not being able to answer all of those questions. If you do want to get in touch, we can probably help you answer some more of them. I'd like to thank you all for attending. And I really hope this has been helpful. We also want to run more of these sort of sessions, so we'd love to hear from you about what you would like to hear about in our next collaborative webinar. So there may be specific things, there may be questions from the list that we can actually run another talk on. In the background, we've had Steve and Ellie pulling the levers, so I want to thank them very much for their participation. Andrew, thank you so much for your input and for creating this test. And it just remains for me to say goodbye to everyone and thank you for attending. It's been a really interesting event this evening, so thank you.